Sorry. Good afternoon, everybody, and thank you for joining us. Today, we're launching a long COVID consortium, and it's in response to interest from a couple of senators, Senator Young and Senator Marshall, who's here, who have a deep interest and have been talking a lot about this issue, but also in response to my own personal experience and the calls that I get almost every day from people who are suffering from long COVID across the country and don't know where to go and feel that their voices aren't being listened to, including members of my own family. We wanted to do something different in response to this pandemic. In the past, the response to epidemics of this kind has been to pump a lot of money into ivory tower science to try to solve the problem. We've already put $1.5 billion into NIH to solve long COVID, and we've got literally nothing from it. And one of the mistakes that we've made in the past is to not talk to the doctors who are actually treating the disease. During the HIV epidemic, there was a policy in the federal government to simply stop talking to those doctors and to discredit them. There was extraordinary science going on, and with particularly with the gay doctors in New York, San Francisco, and Los Angeles, who are finding great success in treating their patients. And those doctors were shut down in the process, but also there was an initiative by the federal public health agencies to shut them down and to deny access to the repurposed drugs that they were using to treat patients very successfully. There was a movie called Dallas Buyers Club that was made about this. And my uncle said that Senator Ted Kennedy actually became an advocate for those patients and ultimately made an agreement with Dr. Fauci, who was shutting those doctors down, to fast track the treatment, testing, clinical testing of the repurposed treatments, the off-label treatments that they were having so much success with, and to allow patients to get access to drugs that they and their physicians believed were going to be helpful and not having to import them from Mexico or Europe or Canada. The same thing happened during the COVID pandemic, where repurposed drugs that were being used by physicians across the world and being used very, very successfully were not only not investigated, but they were shut down and people's access to them was denied. And we want to make sure that that mistake never happens again during disease crises, during contagion crises, and that we start listening to doctors who are on the front line and the doctors who are treating patients successfully all over the world. There's approximately 15 million frontline physicians in the world, and many of them are imaginative, they're great healers, and they find solutions that the ivory tower often doesn't see. And so we want to, first of all, open up a dialogue with those physicians and then give us some mechanisms for assessing the efficacy of their treatments and doing the other things that we need to do. For example, to identify biomarkers, to identify and characterize symptomology. Right now, CDC lists about 300 symptoms to long COVID, and people, virtually everybody falls into one of those categories. And we want to do everything that we can to narrow that constellation of symptoms, and then to be able to assess these unconventional treatments and protocols that people are using, and find out from the patients themselves, from the physicians themselves, which ones are working. So this is partially a listening session, but it's a lot more than that. It's a session in which we are seeking to find alternatives. We're seeking to find solutions. where we want to, for example, start a website that helps Americans locate doctors who are successfully treating these diseases, and gives us a way to assess the success and the efficacy of those treatments. And we don't know exactly what that's going to look like. And one of the reasons we wanted to meet with these people, this esteemed panel today, is to get their ideas about how to construct a website that will really be useful to patients and physicians around the country, and that will give the public health establishment an ability to evaluate the success of various protocols. So I want to welcome all of you today, and let's begin by introducing ourselves. Maybe Dr. Redfield, you would start. We'll go around clockwise.
I'm the former CDC director. I'm an infectious disease physician by training, and I'm currently involved in clinical practice largely for long COVID and mRNA vaccine injury.
My name is Holly Olson. I am a long COVID survivor, and my kids and I all have long COVID from Utah. I'm also a registered nurse with a bachelor's in science and have done a lot of research on this. I've had my journey of the long COVID affecting my connective tissue and all of my body where I could not even walk or move. Have utilized lots of different treatments and have found that stem cells and have helped quite a bit, ethical sources of stem cells. So I wrote a stem cell bill for Utah, which allows treatments to be done in Utah, and have passed another one in Florida, and I'm working in other states. I've also have found that monoclonals have been a huge helping factor in calming the immune system down, along with peptides that have been also very helpful, and hyperbaric oxygen therapy has helped me and my kids and several of my long COVID friends. We are just grateful to have, be able to discuss this and to get some ideas to get people better, and I appreciate this time.
Hello, Mr. Secretary. Thank you for having me. It's an honor to be here with you all. My name is Devin Russell. I'm a co-founder of the Long COVID Foundation. Thank you for affording me the liberty to wear my mask. I think once I explain my history here, you might understand why I would wear one. First, I want to hand out a one-pager on some of the long COVID community needs. I had long COVID starting in March of 2020. I've had it for 5.5 years now. I did not take the COVID vaccine. I alone have had 170 plus symptoms, some very severe, Guillain-Barré, blood clotting, heart issues, brain dysfunction, and even delirium at a time because my brain was so inflamed, which it still is inflamed, but not to that level, but it's still a problem for me. I was near death at times, and that's not a hyperbole. I thought I was going to die. Prior to that, I had chronic Lyme for 11 years, which I recovered from, and I managed a chronic illness-centric clinic for 4 years. So based on that experience, I can tell you long COVID is a unique kind of hell. This is an urgent crisis that needs action now, as I'm sure you know. People are suffering and even dying, and a lot are holding on by a thread. So some of the things we need, of which there are many, but well-run common sense trials, biomarkers and tests, and development of antivirals and other drugs, because we have no tests, no biomarkers, and no treatments right now approved. So I look forward to discussing this in more detail today, and thank you.
Thank you.
Good afternoon. I'm Darcy Johnston, the Principal Deputy Director of the Intergovernmental and External Affairs Office in the Office of the Secretary.
Hi, Ken Callahan, Head of Policy for the Secretary. Just want to thank everyone for coming, and this is something the Secretary has been very adamant and focused on making sure we brought together a roundtable of physicians and patients and other advocacy groups to make sure he could hear directly from them. This is something also he has stressed he wanted to make sure was live streamed So is open to the public, part of his campaign to make sure there's radical transparency. And then also just wanted to address the invisible illness, which there are many in the U.S., and Secretary and the team here is committed to making sure that we get a voice for everyone who is suffering from them. Thank you, everyone, for coming.
I'm Jim O'Neill. I'm the Deputy Secretary of HHS and Acting Director of CDC. So here in this room, you have the heads of 4 of our science divisions and 1 of our data divisions. We're all eager to learn more about long COVID and do excellent research and come up with solutions for everyone. So I'd say long COVID is in the same clinical category as Lyme and Epstein-Barr and chronic fatigue syndrome, which is no consensus yet on biomarkers, no consensus yet on diagnosis, no consensus yet on causes or treatment, but definitely an important, urgent challenge that we need to discover everything we can about it.
I also want to mention, and we're going to do a very similar roundtable, I think, next month on Lyme disease, which has a lot of interactions and similarities.
Right. Thank you, Mr. Secretary. Roger Marshall from the great state of Kansas. I'm here today representing and speaking for, fighting for the 20 million Americans with long COVID. And it is personal, just like your stories, Mr. Secretary, in that I've had a loved one with long COVID for 3 years. And I want to take a moment to acknowledge some of the people in the room. It's different being the doctor on the other side rather than trying to help somebody out. It's been very humbling, but I'm so grateful for them. We've reached out to hundreds of doctors and tried to figure out who could help my son, and acknowledge Dr. Jordan Vaughn here, who's kind of the pioneer of vasculitis. Something as an OBGYN, we talked about pelvic congestion syndrome and cardiac output return. So great to see you, Dr. Vaughn, here. And out in the audience in the next panel is Dr. Bruce Patterson, who has a diagnostic tool. He absolutely has one. I believe it's the right one. And thanks to Dr. Bhattacharya, who's going to let him continue to prove that that's the right one. The Secretary talks about, confirming other people's studies, and that's exactly what we're going to do. And the great thing, it helps delineate the difference between reactivation of Lyme's disease versus long COVID. So you're right. Outside of the ivory towers, there are people that are out there at warp speed time trying to solve the problem. And of course, my mentor here, Dr. Redfield, has also helped my loved one in kind of quarterbacking all the different approaches out there, and just kind of keep the keeper of all knowledge, and just always brings a word of hope to all of us. So I'm honored to be here, and we're gonna whip this thing, Mr. Secretary. We're gonna get to the bottom of it. Thank you.
Great, thank you, Senator. Great to be here, and my name is Marty McCary. I'm the FDA Commissioner. Mr. Secretary, thank you for making this a priority. We have been talking about so many competing important areas in healthcare where we desperately need to push the field towards a cure, and this was a massive priority for this Secretary, so that's why we're here today. Thank you. Long COVID is real. It's been underestimated and overestimated. We are here today to try to help those who are suffering from long COVID. We've spent $1.5 billion with essentially nothing to show for those dollars that were allocated. A lot of hospitals got rich with more MRIs and CAT scan revenue, but in the end, the people suffering with the condition are still struggling. We do know that we have some data points. The presence of long COVID appears to be proportional to the duration of COVID illness and the severity of COVID illness. Thank God both of those have decreased significantly over time, and so we don't see as many new cases today as we did in the past, but people who developed their long COVID symptoms in the past still deserve answers. They've become forgotten to many people. We do know COVID illness is an antibody-mediated phenomena, and antibodies can do a lot of things in the body that are not always anticipated or recognized early on. And we know that COVID illness creates general body inflammation. Guess what most illnesses in the entire field of medical science are due to? generalized body inflammation, insulin resistance, and metabolic dysfunction. And so maybe we are seeing some of the same common principles that could apply to other illnesses if we can crack this code. So I'm here to learn and to listen, but we are committed at the FDA to supporting this agenda. So thank you.
I'm Jay Bhattacharya. I'm the director of the National Institute of Health. When I was in the Senate hearing for my confirmation, as I was leaving the Senate floor after the hearing, a long COVID patient came up to me and said, "I'm desperate. Please help." And I assured her that we're going to find an answer. The National Institute of Health, it has a long history of finding answers for patients. As the representative of the Ivory Tower class here, Mr. Secretary, let me just say, I want to make sure that we're not just in the Ivory Tower. There's folks in the room who have learned about long COVID in the Ivory Tower who've devoted their careers to trying to get answers. But also we have to acknowledge that we have not made as much progress as the patients that we are representing deserve. For the NIH, I don't want to wait to know everything about the physiology of the disease, the pathophysiology of the disease. I don't want to wait to be able to get the perfect diagnostic test before we start to have like real answers for patients. I can entirely agree with you, Mr. Secretary, about listening to the physicians who treat patients, listening to the patients themselves, and then I want to see that those ideas are incorporated in our research agenda. Actually, one of the things I've learned since becoming NIH director is that we've shifted how we're doing our investments in long COVID research toward more practical trials. And we're running, I think several of them now, but we need to expand them to more. I've heard so many great ideas from some of the physicians in the room and from patients themselves. It's going to be a collaboration. It's not going to be us telling you from the Ivory Tower, here's what's real, what's not real. It's going to be us listening to you and our expertise helping to sift, the answer so you can have, the next time we have a commission a year from now, it won't be 20 million people suffering. It'll be, 20 million people with answers, and getting better.
I'm Jordan Vaughn from Birmingham, Alabama. I am the founder of the Microvascular Research Foundation for Long COVID. I'm actually just an independent physician that had the resources to try to help people. And a lot of what's driven me is a lot of the data from the academic world, but being able to utilize that data and apply my understanding of mechanisms of medicines and actually discuss with the patient and figure out ways to help them based on their symptoms, the knowledge we get from the NIH, but also reusing medicines that we know help in those areas. And I think that's one of the things that drives me the most is a lot of solutions. Even there are things that will come, I think, but there's a lot of things already out there on the shelf that we need to evaluate and utilize and actually are very available for people and is very effective in many ways, especially in again, I've treated about 4,000 people. And just the data that I have within my clinical cohort is amazing, but it also informs me on when things don't work and when they do work. And so in many ways, I think actually having a clinician-patient, direction upward and actually suggesting, models and pathology markers and, that is actually the direction it needs to go instead of from the top down. I think actually it's such a patient symptom-based disease with multi-systems that it's going to be very hard unless you listen to patients. And actually a lot of the things that I've learned is actually just by keeping my ears open and spending time with patients and believing what they tell me. And I think that is something that you're not going to get from a textbook. And in fact, a lot of the time what the patient informs you, you utilize your medical education to come up with ways that could happen and then try treatments that might work for it and they become effective. I mean, it's a very different pathway than the classical pathway, but especially when you're talking about probably something that's going to require multiple medications and has multiple systems involved, a monotherapy is probably going to be very hard to come up with. And I think we need to look at it in a very different light. So thank you.
Good afternoon. I'm Michael Paitis. Mr. Secretary, thank you for the invitation. I'm an obstetrician. I'm actually a maternal fetal medicine specialist and a physician scientist. I've been on the front lines for COVID, for acute and long COVID since the beginning. And I desperately wanted to do something to help our patients from the very beginning. My laboratory focuses particularly on brain injury work. And we've developed a therapeutic for acute and long COVID, and we're in the preclinical setting, and we're hoping to go into a clinical trial. And I hope I can be of help to this group.
Can you tell what the treatment is?
Sure, it's a 15 amino acid peptide that is called SpikeNet that blankets the spike protein. And we developed, because in the early days, I wanted to develop an animal model that would help us to actually work with this in a safe way. So we developed a BSL-2 model, which means that it's not as risky, if you will, as working with the SARS-CoV-2 virus. And that allowed us to help understand some of the pathologies. And we then went ahead and studied other aspects to it. So now we know it's different effects, not only in binding the virus, but actually what it's doing to help heal and reverse some of the changes that are occurring in different organs.
Are you finding the same level of COVID in vaccinated versus unvaccinated people infected? Or what are you seeing in that area?
Yeah, that's a great question. So all of this in the preclinical model, is not with using on the vaccine. What we're seeing now, clinically, is that we have a mix of patients that have been vaccine naive and patients that have had it. And I am seeing this in the hospital routinely, not in the high numbers and that we saw initially, but certainly we're seeing it.
Hi, everyone. David Petrino. I'm the Nash Family Director of the Cohen Center for Recovery from Complex Chronic Illness in New York. We're a hybrid clinical and research center in New York City that treats long COVID, chronic Lyme disease, vaccine injury, and other infection-associated chronic illnesses such as ME/CFS. Long COVID first came on our radar in April of 2020, shortly after we'd been hit pretty hard in New York by COVID, and we started to notice some of our patients weren't recovering, so we stood up a clinical program. And since then, we've seen over 5,000 people with long COVID at our clinic. And we recently released a 167-page guide to assessment, intervention, all in an insurance-covered clinic. So we, even in the manual, we cover what CPT codes to bill, how to write. So
what are you finding that works?
So what we've done in the handbook is similar to what you said, Secretary Kennedy. There's 300 symptoms, right? But there are far fewer drivers, and so when we think about what could be causing the symptoms, there's autonomic dysfunction, there's vascular dysfunction, which Jordan does a lot of work with, there's immune dysfunction, there's viral persistence, there's reactivation of other viruses. So what we advocate for is an approach where, also as Jordan said, your patient is your biomarker. You listen to what they're saying. You take a few blood tests. You say, oh, look, I'm seeing EBV reactivation strongly in this person. Their spike antibody is really, really high. Maybe this person might benefit from a combination of antivirals, such as, we've been working with a physician named Skip Pridgeon, also in Alabama, who pairs valacyclovir and Celebrex and Paxlovid. And his results have been really, really quite strong. And so we're trying to bring some of his work into a randomized controlled trial so that we can go to the FDA and say, hey, here's some good quality data suggesting that this really moves the needle on patients who have these specific biomarkers. Because I think the one thing, if you take anything away from this meeting, There's no silver bullet. There's not going to be one drug that undoes everything for long COVID. We really have to look at each patient individually, the same way that we do with HIV care, the same way that we do with cancer care. We need to really understand the uniqueness of each patient.
Dr. Redfield, what are you seeing that works in your clinic? And do you have interactions with other doctors like these?
Well, I do interact with them. Jordan Bond and I work very closely together. He's taught me a lot, and I think I've taught him a little. I tell people it's hard for me to say that he may be better at this than me because I'm pretty cocky. But again, the symptom complex is important. So I focused more on cognitive dysfunction and immune dysregulation. And in that regard, I've looked at ways to try to trick the immune system to reset its set point. So I use some of the earlier drugs that I had used for treating HIV infection. For example, a drug called Maraviroc, which I use quite frequently and have had some fairly dramatic impact on cognitive function in people who literally are so cognitively impaired that they can't speak in more than 2 or 3 words at a time, and been able to get them back to speaking normally. The other thing we've done a lot working with Jordan is become much more aware of pelvic vein congestion in patients, which who would have believed that I have patients that present that really feel like they're suffocating. And it's not a comfortable place to be in a room with these patients because they're 24/7 feel like they can't breathe. And yet their hearts are normal and their lungs are normal, so why can't they breathe? And Jordan helped elucidate and help teach me, and I've followed up on it, is their problem is they're not returning blood to the heart and the lungs. And the reason they're not returning blood to the heart and lungs is because the integrity of their veins, they can't stay open under the pressure of an artery that's over top it. So we see a lot of pelvic vein compression. And what we end up doing, we both have a mutual patient today that's having the procedure done in Denver. Believe it or not, what we end up doing is putting a pelvic stent in the iliac vein to keep the vein open, and it resolves their symptomatology. So there's all different times. You got to really decide what you're going after. For me, largely it's been cognitive dysfunction, where I have a lot of high-performing individuals that no longer can function their executive function. And how do I get their executive function back to the point that they can maintain their job? And again, as I mentioned, the drug I probably use a lot is Maraviroc, rapamycin, probenecid in a combination. And again, all repurposed drugs, none of them approved for what I'm using, but I've had pretty good results in about 70% of the patients. And then, if they have the pelvic vein congestion syndrome, getting intervention radiology or peripheral vascular surgery to evaluate them and potentially put stents in. We have other patients that, as already mentioned, they have a tendency to reactivate other viruses, the herpes viruses in particular, and they cause a lot of the symptomatology of fatigue. And then are there ways that we can help them regain control of their replication of herpes viruses? So it's a very complex disease. It is going to be important to limit the symptoms into categories and to try to compare apples to apples. Because if you just take people, quote, with long COVID, the last thing I'll say on this is there really is probably a difference between patients with post-mRNA injury versus people that have post-COVID symptoms. I will say my post-mRNA injury, which is a real thing, it's real, contrary to what a lot of people think, it's real. Those patients have a tendency of not improving. They just don't seem to be improving. I have a number of patients now that are out 5 years. It's painful. The COVID infection patients do have a tendency to improve over time, despite me doing something or not doing something, although we try to accelerate that, particularly for those people that have so severe cognitive dysfunction. I can tell you the one lady, Joy, is a beautiful woman that I take care of, executive function, mid-50s. She got to the point that she could only speak in about 2 words, 3 words at a time. And she came to see me And I told her at the end of our first visit that she was the sickest person from cognitive dysfunction that I'd ever seen. And she immediately burst into tears. It was very awkward, and she left. I told my wife the story, and my wife lectured me on being more caring.
You need to improve your bedside manner.
Improve my bedside manner. And so Joy came back the following week, and the first thing I did was I apologized to her, and I said, I told you the truth, but maybe I could have done it in a better way. And Joy looked at me, speaking in two-word blurbs. She said, Dr. Redfield, I didn't cry because you said I was the sickest patient that you've ever seen. I cried because you're the first doctor that acknowledged I was sick. And that's the problem with most of these patients. I'd say 5 years ago, 95% of my patients came to me from psychiatry. They were all told it's a problem. Now, some of them actually get to me before they see the psychiatrist, but these patients have really been told there's nothing wrong with them. It's anxiety, they're making it up. No, it's organic. And Joy, I got to put on this combination, Maraviroc, rapamycin, probenecid. And within 3 weeks, she was speaking normally. Her insurance company decided not to renew the prescription. Within 3 to 4 weeks, she couldn't speak again. We got her back on the medicine, and within 3 to 4 weeks, she was speaking normally. So there are things that work. I don't know why they work. I do think one of the problems with COVID that I'm more of an expert on is this post-inflammatory immunoregulatory problem, and how to get the immune system that's stuck over here, how do I get it back in the middle so that individuals can function more readily. So.
Mr. Secretary, if I could just quickly, I'm trying to talk to the folks at home now on this pelvic congestion syndrome. And it's a pretty easy way to self-diagnose yourself if you've got this or not. And it's maybe just as simply if you feel better in a swimming pool, if that gives you some relief, would that be, what else can they do at home just to sort that out?
Yeah, a couple of defining things are legs, non-recovery in the legs. A lot of them additionally have lots of fullness below the belly button. They also have a lot of POTS-like symptoms because of the preload failure of the right ventricle, meaning you're not getting blood back to your heart, which also additionally means pulmonary perfusion is compromised, which makes you short of breath.
What can they do at home?
So the main thing would be, yes, do you feel better in water? But also, a lot of these people, a lot of us don't realize the reason we sleep horizontal is because of the venous system, because it's a low pressure system. So most of these people were people that woke up ready to run, ready to go. And a lot of them now will say, look, it takes me an hour in moving in the morning to get going. And that's a good signal that there is a venous basically venous stasis or venous issues. And again, I go back to this that I didn't even realize 72+% of your blood is in your venous system, and it's not good blood. It's low oxygen, it's inflammatory, it's coagulable. And if it's not moving, in a sense, it's like your sewage not moving.
Yeah, one of the things for your website, Mr. Secretary, which would be so useful, Jordan and I have talked about it, is just to have these patients tell their story. I mean, when you hear this story, I mean, when I first heard it, I didn't understand it. I mean, but now that I've heard the story, I can pick it up like that. You guys have pelvic vein congestion, and we finally get them to, a professional vascular surgeon or a special radiology, and lo and behold, we find out they're 85, 95% compressed. So I think patients hearing other patients' stories can begin to position themselves correctly. Because the average physician, I think, is not educated about this at all. I mean, I won't tell you how many people think that, this can't be true.
But me and Dr. Redfield we argue about what's causing it, which I think is where the NIH comes in. It's so, okay, we see this phenomenon. It's usually happened in women historically. Now about 40% of my patients are male. Usually they're athletic males that are hypermobile, a little more flexible than average, probably some laxity in the veins. But why? And I'm a vascular guy, so I think the vasovasorum, the small vessels to the veins are being compromised, which compromises the smooth muscle integrity of the veins. Dr. Redfield agrees with me, so it's probably right. I'm just kidding. But we need those kind of...
I tell them that the veins major receptor is the H2 receptor, and basically it's a problem with the spike protein dysregulating the H2 receptor and causing inflammation in the bowel wall. But we don't know what the...
Yeah, and that's where I'm saying the clinical things, the phenotypes we're seeing, being able to have some type of mechanism that's really in the background, picking up and seeing these kind of phenomenon that drives translational research to say, what the heck is actually going on here? That's kind of my very different than the top down because you're looking at it from the patient reporting it as opposed to some phenomenon above.
So one of the things that the Recover TLC, this is this sort of the next step in what the NIH is trying to do with long COVID is we had essentially a listening session, a formal listening session where we had submissions from patients, from doctors, and we got 403 submissions about drugs, 64 on diet and nutrition, 29 on manual and physical therapies, 27 on complementary integrative health, and then 28 device submissions, and 21 other, which is, I mean, I thought I'd got through all the categories. So the point is that there's a lot to study, and the question is, like, for us, it's prioritization, right? Like, well, how do we decide which of these are the most promising? This is partly why I said earlier, I don't want to wait. I don't want what we did in HIV, where we're like telling patients, just wait till the randomized trial, wait till the randomized trial. We have to be pragmatic, right? There's so many different sort of conditions, and we have 4 that we're currently doing, four trials. We're doing Recover TLC, low dose naltrexone. This is something we heard from the patient community that worked for some folks. GLP-1 drugs, actually, again, works for some folks. Stellate ganglion block, and then baricitinib. So those are the 4 we're doing, and it's not enough. I have to say, it's a good step forward because we're not waiting to find a full characterization of all the. You can hear among these august doctors that we're still like struggling to figure out exactly what the right mechanisms are. And you guys have seen hundreds and hundreds of cases. So,
well, if I may, I mean, we're currently running dozens of clinical trials ourselves, interventional clinical trials, randomized controlled trials, without any NIH funding. The reason for that is, and with respect, I grew up in the NIH system, so, NIH is very good at doing incremental innovation, which, as Jordan mentioned, that's what we need to understand mechanisms. That's what we need to understand things. But when it comes to, and I'm an implementation scientist, so I know these numbers, but when it comes to, things that the NIH have funded, we go from bench to bedside on average in the United States in 17 years. That is too long. And so I think we need to advocate for more public-private partnerships. We need to get drug companies involved. We need to, there's a company called Invivyd that we're working with right now that produces a monoclonal that could be helpful for both long COVID and for vaccine injury because it can, neutralize spike protein that is circulating in the body. We have not yet had a good size mechanistic trial of a monoclonal to neutralize spike protein. This is an urgent need, and this is something that I think we can achieve rapidly through public-private partnerships. We can go to the FDA and we can say, these are the sorts of things that we need to get, emergency use authorization and labeling, urgent labeling for these patients who are currently paying out of pocket. I met with a patient just yesterday, went out to New Jersey, spent 30 grand on, a monoclonal infusion. That's not achievable, to most people, and not even 1% of people.
Well,
if I could just echo one comment that I think, Mr. Secretary, for you to reflect on, and I've mentioned it to Jay, I think it's so important to get the private sector involved. All right? When I think about how we motivated, for better or worse, the vaccine companies in Operation Warp Speed, we got the private sector involved. I remember Tony Fauci and Collins said that we didn't need to do that, just give the $15 billion to NIH and they'd take care of it in 3 to 7 years. And I made a lot of friends that day. I said, yeah, it will probably take 7 years if that's how we do it. I think we got to get the private sector involved. There's a lot of private sector. I know a number of companies that have very exciting, innovative stuff. And we've got to get them involved. Even in this little room right here, you're looking with clinicians in long COVID, between 1, 2, 3, 4 of us, we're probably taking care of over 15,000 people. I mean, it's not that complicated to put a consortium together and then, partner that with the private sector to bring some of these new innovative therapies. Well, I think that's part of the things you have to engage them. I mean, it's not everybody in the private sector is adverse to using repurposed drugs.
But that's something the NIH ought to solve. I mean, there's something we haven't done enough of, and it's something. I mean, I hear you. You're right, absolutely right. We need to do this much faster. I mean, more agile, and with private sector collaboration, there are mechanisms inside the government to do that, and we just need to use them more.
Yeah, I would just follow up with that. I've had 3 now of STTR SBARs, and that's where you really get at that private and academic partnership, which supported by the NIH, which I think is a great program for drug discovery and acceleration getting to clinical. The second comment I just wanted to make is, you have a number of OBs and GYNs across the country. We do ultrasound all the time. I'm looking at the uterine artery Doppler and all of this day in and day out. So just thinking logistically, we can just engage our colleagues to incorporate this, because we're doing this all the time on the uterine artery and the pelvic veins.
I just want to add, that's why I wrote the stem cell bill, was because we were waiting for FDA to approve ethical sources of stem cells for treatments. And so writing the bill, getting it passed unanimously, both in the House and the Senate, I'd love to do something at a federal level that allows, and it's not just going to help with the long COVID, it helps with autism and dementia and Parkinson's and all these other different diseases. I believe the peptides too will also help with that, along with hyperbarics. So the congestion stuff that was going on, my hands and feet were pretty much black and purple. But when I did hyperbarics, it brought back all of the circulation. I also phlebotomized. I think there's a lot of things out there that we can look into that are going to help us. And I mean, I was waiting for doctors to help me and was not getting the help, or even the hospitals. I had to take it into my own hands and into my own kids. I have 4 kids that all have it. And we have vaccine injury. We also have long COVID, from COVID itself. And so working with some doctors that think outside of the box, Dr. Jones was amazing. He's the one that found the monoclonals. He ran all my interleukins, and then figuring out the hyperbarics, and then the stem cells and the peptides. So there's hope. And that's the thing, is when I felt a little bit better, it gave me hope of knowing this isn't permanent, that we can find things that are going to help us to get even better. So
I would say in this disease process, most patients probably know more about it than your typical physician or internist when you walk in. There's very few diseases like that. And a lot of actually the ideas or things that they come to, sometimes just listening to what worked actually creates ideas in my head on why it worked, if that makes sense. And I think listening, again, getting back to listening to patients, but it's amazing right now the resources that patients have to be able to find out about their issue. The problem is when they try to find something to execute help for the issue that they've discovered is very difficult, because physicians are unaware that this is causing issues, especially even within their specialty and domains. And so imagine going with a disease that you have and a physician that, first of all, may not even believe in it. Second of all, may have never even heard of it. What kind of help are you going to get unless you have a physician that's willing to learn and then try things?
I do think education is important there, Jordan. I mean, great point. But, I did a series, when we released our handbook, I did a series of educational talks across the West Coast to 1,000 PCPs, because I really think PCPs are going to solve all our problems here. No pressure on the PCPs. But they're the people who, when you walk in the door and say, look, I got sick 2 weeks ago, a tick bit me, and I haven't felt the same since, they're the ones who should be identifying, oh, you have chronic Lyme, you have long COVID, you have ME/CFS, or chronic EBV. And we got to 1,000 PCPs in that tour, so we really went for it. And 30% in the door at our pre-seminar interview did not believe that long COVID was real. So that they were happy to mark themselves on a survey saying, I do not believe in the authenticity of this. An hour and a half later, 0% said that. And it was just presenting good quality data to them and saying, this is what and also this is a plan. Here are the things you can try when someone comes in your door.
And I think this gets back to, we do need a good diagnostic tool. And I just can't emphasize enough the mental help of being told that, yes, you're not crazy. Let's just be frank here. These patients have been told they're crazy. There's nothing wrong with you physically. To have a test that confirms, you know, oh, it's Lyme's disease. Okay, great. And I think that maybe we have some of those secrets now unfolding as you say there's 70 symptoms, 150. You probably are starting to put them in buckets now. And based upon those buckets, is there a correlation with some of the testing that we're doing? I'm looking at Dr. Patterson to come and tell us the next roundtable. And then your primary care doctors, you're get them to first base at least. We want to get the PCPs to first base with a little bit more data.
So I think this roundtable already is a significant watershed in validating this disease, putting a lot of information on the table. I'm learning a lot. Mr. Secretary, I'm very grateful that you convened this. And you also asked us to build a website to scale this meeting up into a national level and provide a single place a platform where patients and providers and pharma companies can all share information about symptoms and diagnosis and repurposed drugs and treatments and probably a lot of other things that we haven't thought of yet. And we have our Chief Technology Officer of HHS, Zach Terrell, here listening. He's going to build Secretary's asked him to build a website at CDC for all this information. We have Kristen Honey, our Chief Data Officer. We have Dr. Willie Churtman, our Science Policy Advisor. We're all listening. I'm learning a lot, and we are going to scale this up.
I'd like to add something if I can.
ask one?
Yes, 100%.
Sorry,
Yeah.
my question was, are any of you seeing an interaction with mold?
Yes, I think along with, as Dr. Redfield mentioned, there's this immune dysregulation, and I think immune dysregulation makes your body more susceptible to everything. So for instance, as you mentioned, your chronic Lyme meeting roundtable, something you can take into that is we have data to suggest that a significant portion of our long COVID patients are now testing positive for reactivated Babesia, which is a tick-borne pathogen. And what we think is that they were carrying that pathogen, that parasite, for a very long time, and SARS-CoV-2 reactivated because where does Babesia hide, our vascular people? In the vasculature. It hides in the endothelium. So spike protein agitates the endothelium, and so these other pathogens get reactivated and agitated. And similarly, this immune dysregulation, the immune exhaustion people with long COVID experience, also make them susceptible to mold exposure, make them susceptible to mold injury and other toxins as well.
And there's cells in our body we call mast cells that are very unstable in people with long COVID. And what they end up doing is causing all of this allergic symptomatology. So mold, whether it's mold, hyperreaction, I will tell you that when they get intercurrent illnesses, patients who get an intercurrent respiratory illness, they get it much worse when they're with long COVID than, say, before they had it. So there's clearly a hyperreactivity of the body to allergens, to infectious diseases. Jordan and I do a number of things to try to stabilize the mast cells in the human body. A lot of repurposed drugs that we know can actually help stabilize these cells, and patients do get a lot of benefit from it when we stabilize their mast cells.
Devin, did you have a comment?
Yes, I just didn't want to lose track of the virus because the virus persists and people get reinfected as well. And that's a big problem for people with long COVID. And I know we want to characterize everything, but when I had chronic Lyme, my chronic Lyme symptoms didn't present like somebody else's, but we still had the same underlying problem, which was Borrelia was chronic. So I just want to be cautious about putting everybody into groups when the main underlying problem may be the same thing. Even though there are reactivated pathogens and damage and other things going on, the virus itself.
I think I argued with Jay probably 5 years ago, and I told him there's no viral persistence, there's no viral persistence, this is self-limited virus. Well, I was wrong. There probably is viral persistence.
I think Dr. Redfield's optimism is a good place to end this session. We're going to have in a half an hour, we're going to start our next session on innovation. And I welcome all of you at home to rejoin us. And thank you all very much for being part of this.